Hello everyone, my name is Jeanette Ordonez. I'm a third-year medical student working with Dr. Philip Zimmern. My presentation today is on office flexible cystoscopy and voiding cystourethrogram and the evaluation of women with recurrent UTIs and their influence on treatment. So about 1 in 2 women will experience a UTI in their lifetime, and almost half of these women will recur within the next 6 to 12 months, and some will develop debilitating recurrent urinary tract infections. And so there are many urological abnormalities attributed to bacterial persistence that can be detected by voiding cystourethrogram, such as reflux, urethral diverticulum, and bladder prolapse. Additionally, inflammatory lesions such as trigonitis, cystitis cystica, and vesicular cystitis have been noted on cystoscopy during recurrent UTI evaluation. The presence of resident bacteria in bladder wall biopsies of these women exhibiting cystic lesions was recently reported, which can possibly explain why women with antibiotic refractory UTIs treated with electroporation of these areas experience a significant decrease in subsequent UTI episodes. So this kind of brings to light the potential importance of identifying these lesions on cystoscopy and treating them accordingly. Current AUA guidelines recommend that only upon further suspicion of complicating factors should additional investigative methods such as VCUG and cystoscopy be used. The current mainstay for treatment is still antibiotic use. So due to side effects and concerns about bacterial resistance, there's increasing fear from patients surrounding the negative effects of antibiotic use. There's also increasing frustration towards physicians because we're not addressing these concerns appropriately, and due to ineffective management strategies. Additionally, UTI workup costs can be between $390 to $730. For patients with limited antibiotic choices due to resistance or allergies, IV ertapenem can cost close to $4,000. So these patients are in desperate need for a treatable condition. The combined use of VCUG and cystoscopy to investigate possibly overlooked etiologies has been welcome to help alleviate these frustrations. So simple, well-tolerated, and affordable outpatient investigations such as VCUG and cystoscopy can help these RUTI-related treatable conditions that may be quite cost-effective in the long run. That leads us to our project, where our goal is to review our utilization of cystoscopy and VCUG and the evaluation of women presenting with recurrent urinary tract infections. So we believe that cystoscopy and VCUG will help us identify various urological abnormalities that will then help us create more targeted treatment plans that will help our patients have better outcomes. So our patient population, we have consisted of 124 women evaluated for recurrent UTIs. Of these, only 113 were included in the study because they received both VCUG and cystoscopy. Standing VCUG and cystoscopies were conducted upon initial exam and reviewed for abnormalities that have been linked to causing the recurrent UTIs. So here are our results. There are a lot of numbers on these tables, but I'd like to focus on some of the main points. In about 78% of women, we found abnormal VCUG findings, including large PVRs, reflux, cystoceles, and urethral narrowing, and we found abnormal cystoscopy findings in about 74% of women, including trigonitis, cystitis cystica, and vesicular cystitis. The most common treatment plans after abnormal findings involved fulguration of inflammatory lesions, prolapse repair, as well as mesh removal. And our patient population was mostly Caucasian and postmenopausal with a median age of 67. So our results indicate that women with RUTIs have a significant yield when evaluated with VCUG and cystoscopy, and we found that these findings do in fact influence subsequent treatment plans with potentially disease-modifying procedures such as mesh removal, prolapse repair, and electroporation. So compared to previous similar studies, such as one from Engel et al., they've reported about 62% of women with recurrent UTIs had abnormalities such as cystitis cystica and trigonitis and inflammatory polyps on cystoscopy, which is very comparable to our findings. However, they did not consider these findings useful in the subsequent patient management, unlike how we did. So for our conclusions, this study supports the utilization of flexible cystoscopy and VCUG upon initial examination of women with recurrent UTIs. Our tertiary care center population includes a majority of Caucasian postmenopausal women with recurrent UTIs, which limits our generalizability. So in the future, we would hope to conduct a larger retrospective study done at multiple locations. And additionally, we would like to examine the potential cost-effectiveness of VCUG and cystoscopy in the long term. Thank you for your attention.